This clinical trial is a two-part study. The first part is a phase 1 portion where CIMAvax, the vaccine against epidermal growth factor, that's available in Cuba and in South America. This vaccine has recently shown improvement in patient survival compared to placebo for stage 4 non-small cell lung cancer. So what we're excited about is this vaccine, which has low side effect profile and potential survival benefit. We're trying to see if combining it with one of our exciting immunotherapy drugs, specifically nivolumab, would augment each other's survival effect on patients with metastatic non-small cell lung cancer. So for the phase 1 portion, what we're trying to do is to determine the optimal dose of the vaccine to be used, as well as the optimal interval of vaccination that can be administered that will still retain its efficacy. CIMAvax, the way it was developed was that 4 injections are administered once weekly for 4 doses and then monthly after. So the question becomes if we can combine it with immunotherapy agents such as nivolumab, would it augment the response to the vaccine, thus maybe requiring less of the vaccine over time. So that's for the phase 1 portion. So once we determine the optimal dose and schedule of CIMAvax administration in combination with the standard dosing of nivolumab, we will then proceed with the phase 2 portion, which will be to test this combination in patients with metastatic non-small cell lung cancer and find out whether the survival of these patients will be improved with this combination compared to historical results we know with nivolumab alone. To understand how this vaccine works, we have to highlight that the epidermal growth factor is a normal protein found in one's body. So it's very difficult to develop an antibody response to your own protein. So this vaccine was formulated so that the body will be able to naturally produce antibodies that bind and clear out these epidermal growth factors proteins, so that when you clear them out, you avoid or prevent these EGF, the epidermal growth factors, from binding and stimulating the growth of tumors. Some of the potential known side effects to the EGF vaccine alone include pain at the site of the injection. There is an anecdotal report in the phase 1 through 3 trials of CIMAvax alone of some patients getting a severe rash, which is quite uncommon. So most of the patients tolerate the vaccine very well, except maybe for the nuisance of being injected, pain at the site of injection. Now there are hypothetical side effects that may happen. So as I mentioned, skin rash is one of them. So if you combine it with immunotherapy that will augment your immune response to the vaccine, could you potentially also increase, let's say, risk for a skin rash or risk for diarrhea, which is common to immunotherapy agents and potentially with the EGF vaccine. So those are probably the top 2 more commonly potential anticipated toxicity that we might expect with this combination. So the promise of this combination is that we can synergize the effect of EGF vaccine alone, the CIMAvax vaccine, and nivolumab alone, and that the 2 of them can help each other's anti-tumor efficacy and improve patients' outcomes and survival. So that's the hope and possibility that we can maybe make the vaccine even more effective and make Opdivo or nivolumab more effective too in a wider proportion of patients. So for the phase 1 portion of this clinical trial, eligible patients are patients who are metastatic non-small cell lung cancer, for whom nivolumab will be an acceptable or appropriate treatment regimen. Currently, nivolumab is approved as a second-line therapy upon disease progression after frontline platinum-based chemotherapy. Patients who have known alterations such as in EGFR, ALK, or other oncogenes for which there is a target therapy, they are eligible only after they have progressed on the target therapy and are ready for the next line of treatment. So the phase 1 portion, it varies depending on when toxicities will be encountered, because there are certain rules that we need to monitor. But there's a range. It could be between 12 to 24 patients, depending on the need. And for the phase 2 portion, we anticipate another about 70 patients or so. Because of the logistical issues with this vaccine, there is no compassionate access program at this time. We're only able to get as much as we need to for the purpose of this trial. So at this point, the CIMAvax trial is only being conducted in the Roswell Park Cancer Institute, so patients have to travel to our institute. For the time being, certainly for the phase 1 portion, in its initial period. Ultimately, our goal is that we will be able to obtain approval to distribute this to other participating institutions who would be interested to collaborate with this trial. Because of the nature of the phase 1 trial, wherein we accrue 3 patients at a time and observe them for safety and side effect profile before we proceed to the next dose level, we anticipate that the phase 1 portion alone may take 1 to 2 years for us to determine the optimal dosing schedule before we proceed to the phase 2 portion. And that phase 2 portion may take at least another year or two. The cost of the trial will be largely standard of care. For example, the use of nivolumab is as its indication. The same thing with the imaging scans that we obtain to determine efficacy of the drug. So a lot of the treatments we're doing is standard of care. So cost is charged to the insurance carrier. Now, for the research-related activities, such as necessary biopsies or blood draws or any other research analysis being done to these tissue specimens, the vaccine itself, those are not charged to the patient. So there are financial assistance programs in Roswell, but these are similar to other patients who come here to Roswell looking for clinical trials in general. So there's not a unique or separate assistance program.